My name is Prabhash Kakarla. I'm an internal medicine board certified physician in addition to fellowship training in geriatrics. So as a geriatrician, we focus on four main things. We call them the four M's. We focus on medication, mentation, mobility, and what matters most to the patient. I keep this what matters most to the patient at the top because I try to have more of a patient-centered approach. When it comes to medication, we look at what medication they're currently on. There's often times where I call a patient to bring in their medication, the pill bottles from home, so I can get a better eye on what they're actually taking. Sometimes we find people taking expired medication from 2 years ago. I've had a patient who was also on 36 meds. I can't imagine how she was taking them. We eventually went through the list and started taking away the ones that didn't seem appropriate, and then took away a few more that she no longer needed, and then got to a point where she was doing much better. And then we also look at mentation, which is a cognitive status of a patient. We do screening tests. We do a basic screening as we room a patient, and in addition we do more comprehensive testing for cognitive assessments. We then do examinations on their mobility status. We look at the falls. We look at any difficulty with mobility, gait imbalances, things like that. We then also look at whatever else matters to the patient. We look at and see if they have some advanced care planning, what are their decisions as far as how they want to go about their health care, depending on their comorbidities and how much more, for example, in a patient suffering from cancer, how comfortable they are continuing the chemotherapy or making additional decisions that are more appropriately designed to keep them in the center of the decision making. So some of the common conditions that we see as geriatricians are osteoporosis, heart failure, dementia. We look at urinary incontinence, hearing and vision losses. We talk about frailty, balance disorders. We look at sarcopenia, muscle loss, and helping patients make decisions with conditions such as cancer, and making decisions in their goals of care. We help them to have a better approach towards their chronic conditions like diabetes and hypertension. And then their physical status, as well as also looking at their social activities. I think it's most prevalent because of our diets, and also some degree of family history that could relate to that. But the amount of salt intake here, we don't pay too much attention to it, unfortunately. But I've had patients who were not too happy with considering medication. They started making some dietary changes, started cooking at home instead of eating outside. I've seen blood pressures drop nearly 20 millimeters of mercury just from dietary changes alone, in addition to physical activity, which I think is something that we speak about quite often. I try to make it a point to spend the time with patients to explain to them the bigger advantage by making lifestyle changes, even more so than picking medication or going up on medication, and see how that impacts them in the long run. People do mention that they see better benefits in the coming decades. If you look at studies on aging, there are people that show that they've felt better a decade later after incorporating exercise and physical activity, and making dietary changes. So exercise and dietary changes have shown benefits, significantly more so as you age, within people who have not previously exercised or have been deconditioned due to lack of exercise. When they resume or start, exercise of at least 30 minutes of continuous physical activity, in addition to dietary changes. The changes have been very significant into the 40s and 50s, and going forward even into your 60s and 70s if you haven't previously been able to incorporate that. So there's normal aging as it happens. Age by itself should not be taken as a determinant of a patient's prognosis or their baseline health status. We should take into consideration whatever chronic conditions they have in addition to that, and then making sure that we practice preventative medicine. Preventative medicine plays a big role in ensuring that we avoid some of the common ailments with aging. So that's the reason we do our screenings for colon cancer. For smokers, we do the lung cancer screening, abdominal aortic aneurysm screenings, and then we do our immunizations to prevent worse outcomes if and when you do catch a disease. Piece of advice for a 65-year-old, otherwise healthy, without any prior medical history. We start with doing the screening and preventative measures. In addition to that, I encourage them to maintain a good degree of physical activity, try to maintain a healthy diet, start keeping a watch on what they're eating, and in addition to that, social activity. Start having fun, start going out there, dance more often, get engaged in the community, start spending time with family members.